Friends, welcome to my workplace at Ranaghat, West Bengal, India. In this video, we are going to see management of a posterior capsular rent. After the initial steps, the phaco needle goes in, some superficial cortical lens matter is removed, and now the handpiece is turned to make the bevel up. The nucleus is chopped in this way. This is the first one, first crack. The nucleus is rotated. This is the second chop. The nuclear fragment is free and I emulsify this piece. Hold the second piece, emulsify. The nucleus is not hard. Nuclear sclerosis is about grade 3 or grade 3 plus. Ultrasonic energy used is 70%, flow rate is 40, vacuum is 400 millimeter of mercury. And this is the last piece. And at this time, I don't think anything happened. Posterior capsule appears okay. Go with the Simcoe and remove the cortex. Go with the Simcoe and remove the cortex from this side. But here I see a rent. Probably it occurred during aspiration of the cortex. And now my plan is to implant a multi-piece intraocular lens under air, because if I use visco now, a lot of visco will go into anterior vitreous, and if the vitreous is liquefied, lot of visco will go much behind. So we can implant intraocular lens under air in this way. The incision should be little large so that the cartridge goes inside, and now the haptic is placed over the iris. No attempt is made at this time to place the haptics in the sulcus. Leading haptic is placed over the iris, trailing haptic is outside, and now over the anterior surface of the lens, little bit of visco is injected. And now remove the air. Probably some vitreous strands are already prolapsing into the anterior chamber. And now the trailing haptic is first placed in the sulcus. And now with the help of hooks, the leading haptic is brought at 12 o'clock just in front of the main incision. Then it is pulled little beyond the main incision. Now through the right side port, the lens is dialed in this way so that this haptic goes in the sulcus. And now with the help of triamcinolone acetate, we must check if there is any vitreous strands in the anterior chamber, in the around the lens vitreous strands projecting into the anterior chamber or not. Triamcinolone acetate is injected, it is washed with Simcoe, and we can clearly detect that there are vitreous strands. One strand is coming out through the main wound. So, vitrectomy has to be done, and already I have asked for vitrectomy cutter. Cutting rate is 3000 cuts per minute, flow rate is 20 and vacuum is 200, and this is the trimming of vitreous strands. Irrigation is through 8 o'clock side port and cutter is being used through the main wound. Now the cutter goes behind the lens and some amount of anterior vitrectomy is done. Only just trimming of some vitreous strands just behind the intraocular lens. We must use triamcinolone acetate judiciously, should not use lot of triamcinolone acetate. It can cause raised intraocular pressure in many cases, so you have to be cautious. Yes, some vitrectomy has been done, some more air, and this is pilocarpine. The side port is, this is moxifloxacin, and now the side ports are closed by hydrating corneal stroma. And a final lavage of the anterior chamber. The pupil looks round, but on more final check whether any vitreous strand is there or not. Inject little bit of triamcinolone, not much, just little bit, and check if there is any vitreous strand. And I can see a strand which is coming to the main wound. To confirm it, I take a Sinskey hook, go through the side port, and I find that it is there. So I take the cutter again, irrigation through right side port as cutter through the left, and here I cut the vitreous strand. And this is the final stages of the surgery. This patient did very well. At 1 week post-op, the patient had normal intraocular pressure, quiet anterior chamber, no corneal edema, unaided vision of 6/12. Patient was happy. This is closure of both the side ports by hydrating corneal stroma, and a final lavage of the anterior chamber is done with Simcoe cannula. The antechamber is nicely formed. Integrity of all the wounds are checked, and the case is concluded. Thank you very much for your attention. Hope this video will help you in developing your surgical skills. Be a great surgeon and serve your patients with love, respect, empathy, and great surgical competence.